Good morning, everyone. Today we'll have a talk on developmental midline nasal masses and overview. Will be presented by Dr. Mohammed. Over to you, Leila.
Morning, everyone, and thanks, Delia. So this morning I thought I'd do a presentation on something that's quite rare, but we did see a patient in our clinic not so long ago, and I thought it was quite a nice topic to speak about, just to give an overview to everyone. It's not something we encounter commonly, but I think it is something we all need to be aware of because we might encounter it at some point. I have no disclosures and references are all acknowledged and obtained consent from the patient for use of images and all the information. So this is the patient. She was a 10-year-old female, previously well with no comorbidities. She was non-syndromic. She had a nasal tip pit since birth and presented with a 1-month history of a painful red swelling just above the pit. It was intermittently discharging pus, and she showed a minimal response to antibiotics given by the local clinic. She had no history of trauma, no visual impairment, no rhinorrhea, no epistaxis, and no hypoanosmia. She was actually initially seen by the plastic surgeons. They unfortunately didn't do any preoperative imaging, but took her to theatre and did an incision and drainage of this inflammatory lesion, but didn't address the pit. She then went home and then represented to our OPD after referral from plastic surgery. She presented to them with a recurrence about 4 months after her index surgery. She was then booked for an MRI, but unfortunately the patient was lost to follow-up and we're still attempting to trace her. So just to dive into the topic, so these types of lesions, as I mentioned, are very rare, and they result from aberrant embryological development. They occur in about 1 to 20 to 40,000 live births. The most common of these masses are dermoid or epidermoid tumors, nasal cerebral heterotopias, also known as nasal gliomas, or nasal encephaloceles. Less common lesions are simple kind of inclusion cysts, hemangiomas, or even aberrant ethmoidal sinuses. And in view of the potential intracranial connection, patients are at risk for intracranial complications like infection. And so lots of authors advocate for early surgical correction. So as I mentioned earlier, the commonest types are the nasal dermoids, nasal glial heterotopias, previously known as gliomas, and nasal encephaloceles. And I'll go through the embryology a bit later and just kind of touch on how these lesions come to be. So to me, I don't know about everyone else, but to me, the embryology is still quite obscure. But what we do know is that it happens very early, within the first 12 weeks of fetal development, which is a critical period for nasal development. So this is I know it's quite wordy, but this is a summary. I've tried to summarize the embryology and just to make more sense of how these lesions come to be. So they appear in the midline in the regions of embryonic fusion, and the specific locations, the fetal locations, are the fronticulus nasofrontalis, which I've highlighted here, and that's the space between the frontal and nasal bones. Also the prenasal space, which is between the nasal bones and the nasal capsule. The nasal capsule is basically the precursor of the septum and nasal cartilages. And then also the foramen cecum, which I've highlighted in picture B. And that's located along the anterior cranial fossa, anterior to the cribriform plate and posterior to the frontal bone. And the frontal bone is quite an important structure in the development of these lesions. And this is all within the frontoethmoidal suture. So during normal development, these spaces will be closed by fusion and ossification, but during aberrant development, a projection of dura protrudes through the foramen cecum and it persists. And if it maintains its attachment to skin with the underlying fibrous tissue or the nasal capsule or the dura, the epithelial elements can be pulled into the prenasal space with or without a dural connection, and that explains the intracranial connection that some of these lesions may have. In terms of the pathogenesis, so there are two theories. There's the cranial theory and the superficial theory. So during development of the frontal skull base, the dura that retreats from the prenasal space adheres to the skin, and then that results in this persistent sinus tract. And then in the superficial theory, there's abnormal fusion at the nasal root with submucosal trapping of the ectoderm, and that's responsible for the formation of a sinus or cyst. And then just in terms of terminology, cysts that contain adnexa are classified as dermoids. And then if an epithelium line tract extends through the nasal septum to the foramen cecum, which I mentioned earlier, then the anomaly will be classified as a sinus or a fistula. And this is just an image of the pathologies that I've described. So you get a nasal encephalocele where there's a direct communication intracranially, and it's not connected just by fibrous stalk, but rather by a pedicle with a lumen. A glioma maintains its connection to the dura, but just by a fibrous stalk generally. And this is a fistula or dermoid cyst, where it can be located at different depths, but basically there's no intracranial connection, neither by a lumen or a stalk or any fibrous band or anything. In terms of the differential diagnosis, I think it's important to keep it wide and not label the patients as having something just because this is what you know, but keep it wide. So inflammatory lesions like an abscess, just remember that this can occur concurrently with the underlying congenital developmental abnormality. It can be a traumatic deformity, so always ask patients about any previous trauma. Benign neoplasms can occur, so polyps, JNA, hemangiomas, these are all intranasal, but these lesions I'm talking about can present as intranasal masses. They can be malignant neoplasms like rhabdomyosarcoma and lymphoma, especially in the pediatric population, and then congenital masses like teratomas or hemangiomas. So in terms of the workup, imaging is quite critical, and CT and MRI are most commonly used. So the CT findings are that of a fluid-filled cyst. It can be a soft tissue mass, an intracranial mass. You can get enlargement of the foramen cecum and distortion of the crista galli. Specific CT findings suggestive of intracranial extension of communication for a enlarged foramen cecum and bifidity of the crista galli. But quite interestingly, from what I've read in some case reports, is that these findings are actually quite common on young children's CT scans, so they aren't necessarily diagnostic or pathognomonic. Findings are actually valuable if they are absent, because when they're present, they actually might be false positives, as I mentioned now. And you should bear in mind the age at which the scan was done and the age at which you're seeing the patient, because of ossification of the bones occurs at different stages. And in this picture, you can see I've just highlighted what widening of the foramen cecum looks like on an axial CT. So moving on to MRI, some experts actually consider it first line, and that's because it immediately answers your question of whether there's an intracranial connection or not, and it also describes the extent of the lesion best. And at the same time, it also saves the child exposure to radiation, which we know a CT is, in terms of a CT, is very significant. It also gives much better soft tissue delineation. And there's an author who in the late 1990s, I know that's quite a long time ago, but he had a report of about 36 children with dermoids, of which 2 of those patients had a CT suggestive of intracranial involvement, and when they were taken into surgery, this was not actually found. And this gives a bit more evidence for doing an MRI if you're planning in surgical intervention. So most authors nowadays would actually recommend both a CT and an MRI. And this is for the reason of assessing intracranial extension, and also allows you to plan your surgical approach better. And this image alongside just is a sagittal MRI showing quite nicely a very well circumscribed glabellar dermoid, which I'll go into more detail in a bit later. Just a note on workup. So if the patient presents with a clear discharge and you need to rule out whether this is CSF or not, the best way of doing this is to confirm whether there's beta-2 transferrin present in that discharge. And this is a protein that's present in CSF, lymph vitreous tumor, so it's quite specific. It can be performed on quite small samples, but you should always check with your lab before it does. It is dependent on the assays used by the lab. There is a small false positive rate, and some labs will then request a serum test, but what's quite important is in contemporary practice, there's no role for the halo or glucose test. I've put up an image of the halo test at the bottom here. And then just going over the treatment principles in brief. So generally the treatment is surgical, and what you aim for is a complete excision, and the approaches are where you can have a discussion. So you can do an open approach or an endoscopic approach. I'll go through them a little bit more in detail later. And generally, most authors advocate early intervention, and this is to avoid nasal distortion, bony atrophy, osteomyelitis, or any of the intracranial complications, and meningitis is one of them. And then in terms of dermoids specifically, you must aim to excise the entire tract in order to prevent recurrence, and the rates of recurrence are high if you don't. Okay, so going further into detail on nasal dermoids. So how they present, so they are basically the commonest congenital midline nasal mass, and it's most likely what our patient had. This has ectodermal and mesodermal components. So if it's only got ectodermal components, then it's actually called an epidermal cyst. But if it's got all three, so ectoderm, mesoderm, and endoderm, then it's classified as a teratoma. They can present quite variably. So just a single isolated nasal pit, they can present with a fistula, they can present with a complication like an infected mass, and this can be anywhere from the glabella to the columella in the midline. And sometimes they present as a single cutaneous tract with hair at the opening, and this is more suggestive of a teratoma. The possibility of intracranial extension does exist with nasal dermoids, but it's variably reported at a rate of about 4 to 45%. That's quite a wide range though, so you should always consider it. And you should always ensure to ask about a discharge, and specifically your aim is to find out whether it's CSF or not. You can do the beta-2 transferrin test. However, this is very, very uncommon. And mostly the type of discharge you'll see from these lesions is a sebaceous type fluid or a pussy type of discharge. In terms of associated congenital anomalies, also very variably reported. The range is also wide, 5 to about 40%. However, it hasn't yet found to be associated with any specific or known syndromes. Just going back to the possibility of an intracranial extension, this is why imaging is essential before planning any kind of intervention. Complications, so we should be aware of these because the patients may present at this stage. So if these are left untreated or the patient presents quite late, they can get something like a local cellulitis or inflammatory skin changes. They can present with an abscess like our patient did, or even an osteomyelitis. So that would be like a chronic draining fistula or sinus. They can have cosmetic issues depending on the size and location of the lesion, and then intracranial complications like a meningitis, frontal cerebral abscess, if there's a intracranial connection, and also a CSF leak if there's breach in the dura. In terms of nasal dermoids, the treatment of them, so the treatment of choice is basically complete surgical excision, and you want to preserve the entire wall of the cyst. And by preserve, I mean not disturb it or breach it. And this is for the reason of recurrence. And recurrence can range from about 50 to 100%. And this is when the cyst wall is breached. The approach can be endoscopic or open. Generally, mostly it's done open via midline incision, an external rhinoplasty incision, or even a transverse rhinotomy. The timing of it, well, as I mentioned earlier intervention avoids infective complications, as well as it's sometimes better for cosmesis. Clinical observation is sometimes a viable option after you've ruled out that it's not a malignancy, or you've ruled out that there's no intracranial involvement. And this is in patients generally without cosmetic impairment. If there is a noticeable cosmetic deformity, but you have ruled out a malignancy or intracranial extension, then the choice between surgery and observation should be discussed with the patient and their family. So more in detail about the glabellar dermoids. So this is an adult patient that I've pictured, but it does occur in the pediatric population, can present in the pediatric population. So it's typically a firm midline pea-sized lump at the glabella. The MRI shows a well-circumscribed lesion at the glabella, and it's very rare to have an intracranial connection. These are the easiest to manage because you essentially do a midline vertical incision over where the mass is. You raise the periosteum around the lesion and ensure to resect that with the specimen. And then what they describe is that you're often left with a quite deep bony indentation, but that's got very little cosmetic impact, and it generally heals very well. Mid-nasal pits is also a form of a nasal dermoid. So here the MRI is also very useful. It's very important to recognize and identify the pits. In our patient, I think the pit was initially kind of overlooked or missed. There's also variable deeper or superior extension, and they can actually be very localized and easy to resect. But at the same time, that being said, what you can see could only be the tip of the iceberg. So this also would require a midline vertical incision with an elliptical incision around the pit in order to excise it in its entirety. And then you remove the bone as required, and you allow your scan and also your clinical intraoperative findings to guide you there. And this is if the cyst extends beneath the bone. And then important in these lesions, as with all the other lesions, actually is meticulous closure. You're operating on kids generally, and so you want to give them the best type of cosmetic outcome. This image alongside is a sagittal MRI. It shows a mid-nasal pit. There was no externally visible mass on this particular patient, and you can see there's no superior or deeper extension. And then the nasal tip dermoid. So these often occur without a pit. They can have a very thin skin overlying them, and they may extend posteriorly into the cartilaginous septum. They may also extend superiorly to the skull base, and the general preference is also an external approach via rhinoplasty. And here in this image, this is also sagittal MRI. You can see that there's a small nasal tip dermoid, but there was no superior extension. Okay, moving on to nasal gliomas. So these are basically glial cells, which are in a connective tissue matrix, and some people describe it as encephalocele that have been sealed off from within the nose. They can be found at the glabella, at the nasomaxillary suture, or even intranasally. So they have a variable location. The frequency of these, so an intranasal mass occurs in about 1/3 of patients, extranasally more commonly, so 2/3, and inter and extranasally can occur as well, and that's in about 1 in 10 patients. About 1 in 5 patients will present with a fibrous intracranial connection, and this is a fibrous stalk without a lumen. If there's a lumen, it's actually an encephalocele. They contain dysplastic brain tissue, but there hasn't been found to be any malignant potential. And there is a potential for CSF rhinorrhea and meningitis because of the intracranial connection, but this is also quite variable. So in terms of the intranasal mass, how they look, it's been described as red or bluish, firm and polypoid in nature. So it may be mistaken for just simple inflammatory polyps. And they usually this is quite important, they usually arise from the lateral nasal wall or nasopharynx. In terms of the extranasal presentations, it's firm and non-compressible. There's no change with crying, and by that I mean there's no enlargement of the lesion. And then what has been described is the Furstenberg test. So this is a test that's now said to be of historical relevance. And basically it's a clinical test where if you occlude the ipsilateral internal jugular vein, if the lesion is found to increase in size, then it's more likely an encephalocele. But this test has now been superseded by MRI. But in nasal gliomas, the Furstenberg test has been said to be negative. And I think it's still something that's quite interesting to try and evaluate if you are seeing such a patient. In terms of the hypothesis of how these lesions are formed, so it's similar to that of nasal dermoids, and they develop from extracranial crests of glial tissue, and you get abnormal closure of the ventriculus nasofrontalis, which is that embryonic structure I mentioned earlier. Another theory is that they're possibly encephaloceles that have just lost their CSF or CNS connection. Moving on to the management. So again, surgery is the mainstay. You can do an endoscopic or open approach, a lateral rhinotomy, which is the picture on the top that I've put there, is one of the approaches that you can use, or you can do alar incisions, or for the intranasal gliomas, or you can do combined approaches for the inter and extranasal gliomas. If it's isolated to the intranasal space, then endoscopic excision may be all that you need. And if it's extranasal, then you should tailor your approach basically according to the location and size. Several authors have described isolated cases of endoscopic excision of small gliomas that have intracranial extension. However, this isn't commonly done. And takes a lot of skill and training, I guess. And it's essential to ensure that you get complete removal, because also in this case, you want to avoid recurrence, which occurs in about 10% of patients. Moving on now to the last one, which is the nasal encephaloceles. So how these present, so they are classified as, how they present is based on how they're classified. So they can be frontoethmoidal or basal. The frontoethmoidal type is the commonest, and they can present with basically just a nasofacial swelling. The basal type is less common, and they can present with an intranasal mass, and that's because of it's basically a defect in the cribriform fossa sphenoid. They described as being bluish in color, soft and compressible. They transilluminate, and they can be pulsatile. They also enlarge when crying, and the Furstenberg test is described as being positive. They originate medially in the nose, and this is important clinically because you can't pass your scope or probe medially to the mass. This is versus a glioma, which, as I mentioned earlier, originates laterally. And they may also have an associated CSF leak. And this occurs more commonly than in the case of a glioma or nasal dermoid. And these are just some nice images of a nasal encephalocele. So here you can see a coronal CT scan with a lesion on the right side. This is the same patient who had an MRI. This is a coronal MRI, also showing the lesion quite nicely. And this picture I put here to show that there is a pedicle or stalk with intracranial connection. So that's definitely an encephalocele as opposed to a glioma. Basal encephalocele, so they can present as an asymptomatic mass. They can present as an intranasal mass, a mass in the nasopharynx, in the posterior orbit, because they also can herniate through the cribriform plate or posterior to it. And here, importantly, is the potential for airway obstruction in the neonates, especially. They can present as a unilateral nasal polyp in children. You should always ask about rhinorrhea and test if it's CSF, and always consider nasal obstruction in cases of respiratory distress, especially in the neonate, with small structures and small airways, and these patients may even need a tracheostomy in order to secure their airway before you intervene on anything else. This is a patient seen by the neurosurgeons at Red Cross, who just sent us the picture, but they operated the patient and because it was an encephalocele and had quite a large intracranial connection. But just to show you the variability in how they can present. In terms of their treatment, so in the past, they required a combined approach with neurosurgery, but even now, I mean, it depends how they present, right? So they would need a frontal craniotomy, you then excise the intracranial component of the mass, then address the bony dural defect after that, and then the extracranial mass is removed subsequently. An external approach, if they are, if amenable, you can do a lateral rhinotomy. And more recently, there have been descriptions of endoscopic repairs, but it's very much dependent on how the lesion presents and where exactly it is, and the extent to which the intracranial connection exists. Yeah, so that brings me to the end of the talk. So as mentioned earlier, these lesions are very rare, but must be remembered in the differential for a patient presenting with any kind of nasofrontal mass. It's important to know the differences between them because they have different managements sometimes. All children with nasal masses will need imaging in the form of an MRI and a CT, maybe both, and an MRI is recommended generally if the CT raises suspicion of an intracranial connection. And you should never try and biopsy these masses without imaging, and that's because you do put the patients at risk of a CSF leak if there's an intracranial connection. surgery is still the mainstay of treatment and the treatment of choice, but it's not always necessary, especially if there's no history of infections, if there's no suspected malignancy or evidence of intracranial extent, and if cosmetically the patient and family are happy. There are also recent articles which advocate for endoscopic approaches for superior cosmetic outcome. However, it's not obviously gained widespread popularity, and it takes a certain amount of skill and technique in order to do those in a way that gives the patient the best outcome without a recurrence. Yeah, so these are my references, and I think now we can maybe have a discussion and take some questions. I've got Dennis, Dr. Katundu here with me, also to provide some insight.
Thank you, Leila. That was a very nice presentation. We'll definitely like to hear from Dr. Katundu, his opinion on this pathology.
Thanks very much, Leila, for this nice, well-done presentation, which highlights a very good component of the NASO lesion in children, especially with the one with highlights of a congenital origin. To be very precise and broad to especially many people practicing around the developing world, it is so important to consider all these kind of differences that Dr. Leila has mentioned out, but always try not to touch this region until when you have imaging, because you can see this case which we had received from our side. People went forward for planning for drainage, and they never had any previous imaging, and which proved them to say so wrong. But for us, people who practices in Africa and the rest of the developing world, please try to have images, try to have a very good history obtained from the family and the parent. And again, don't forget that there are syndromes which associated with congenital nasomasses. So when you have this patient, try to also go in detail to ascertain for any syndrome which might be in line with the presentation. Otherwise, we welcome questions and other input from the other side. Thank you.
Thank you. Any other comments? Okay, any other comments from the participants? Okay, thank you so much, Leila. And we'll have another meeting next week, Wednesday. Have a nice day, everyone.